Thank you very much, and I think it's a difficult role to play following the mayor of arthroscopy in terms of any talk. I am Mark Hutchinson. I am one of three faculty people, actually four, that represent the Arthroscopy Association of North America. I currently sit as the chairman of the International Committee for ANA, so greetings from ANA. I certainly want to thank the Egyptian Arthroscopy Association for its kind invitation, and specifically want to thank Professor Aziz, Professor Hamed, and Professor Morsi for their hard work in putting this together and for allowing us to participate. It is an impressive conference that you guys have put together. Hopefully that's better. I have no formal disclosures. What I'm going to talk to you a little bit about is, again, some of the challenges that we currently face regarding degenerative meniscus tears. As we probably all should know, probably most of the time now we've been told by colleagues and other literature that says maybe we shouldn't be doing diagnostic arthroscopy on degenerative meniscus tears. This actually began with the work of Dr. Mosley in 2002, where they really did an interesting study where they randomized arthroscopic surgery for degenerative changes in the knee. It included degenerative meniscus tears. If you ever read that study, it's particularly interesting because what they did is they blinded patients and they did a sham operation, they did a washout operation, just a lavage, and they did a meniscectomy and cleanup. And what they found out then later, when the patient didn't know, they just asked the patient to go, do you feel better? Do you feel about the same, or you feel worse? And the bottom line is they couldn't tell if you did arthroscopy and debridement or lavage or anything with those. And so that triggered a number of different studies for degenerative meniscus pathology. And it's really affected us as orthopedic surgeons in terms of having a liberal ability to do these arthroscopies. Why? Because first they said, maybe that's just arthritis. If you have a degenerative meniscus, that would be okay. Actually, over time, we've learned that even that doesn't work that well. How about with mechanical pathology? Well, actually, the farther you go on with all of these studies, all the way to the most recent studies in 2020 from Savonin and others, bottom line is most of our knee arthroscopies for degenerative meniscus aren't particularly effective. So what's the response to that? In 2016, at the ESCA, they created a meniscus consensus statement. Basically, what they said is, if you presented with somebody with a degenerative meniscus pathology, the bottom line is that you should really try non-operative things first. And so that's going to be physical therapy, bracing, injections, and you do that for about 3 months and see how that's going to work. And if they still have complaints, then you get your MRI scan if it wasn't already done. And then if they have mechanical pathology, then it's okay to try the arthroscopy. The American Academy of Orthopedic Surgeons in 2022 created this broad response to degenerative pathologies of the knee. And basically, if you look, some of the small pink areas are basically negative things, and that is to say there's a strong recommendation that you shouldn't use lateral wedge insoles, you shouldn't use oral narcotics, and you shouldn't do arthroscopic lavage for degenerative meniscus pathology. But interestingly, all of the other ones are actually positive things that you actually can do to address a degenerative meniscus. And according to the Academy in 2022, actually a partial meniscectomy is still a moderate recommendation to support. So it's something that you can consider doing, but even that recommendation would suggest after you failed conservative treatment. This is a study from 2018 that looked at some of those questions from some of the key organizations. The Academy, the American Orthopedic Association, a variety of different things. And what they finally showed is if you see the ones in the pink on the left, bottom line is nobody's going to encourage just simple lavage or debridement for somebody with arthritis. However, if you have degenerative meniscectomy, and so that's associated, if you look at those consensus views, doing an arthroscopy and partial debridement is not unreasonable. But how about let's look at what some of our colleagues have suggested, particularly suggested by our primary care colleagues, that said we as orthopedic surgeons are doing way too much arthroscopy and doing too much surgery on these degenerative meniscus pathologies. And so they did a Cochrane review. These are 16 randomized controlled trials, over 2,100 participants. And what it basically showed is, in all honesty, when compared to placebo surgery, just basic washout, surgery led to little or no significant difference in pain, function, quality of life, or patient satisfaction. Now, if you look at those numbers carefully, actually, while there's no significant difference, in every category, there's a slight trend to favoring arthroscopy, but only slight. So here's a nice study that was done by Brian Cole and his colleagues at Rush in Chicago, and he was looking at, okay, is it okay to do a primary arthroscopic partial meniscectomy? And they looked at patient-reported outcomes, looked at things like the IKDC and the KOOS studies, and then they were looking for minimal clinical important differences. So when does it actually make a difference? Not just that they said I felt a little bit better, but it was significantly different. And what they found is that in 269 patients, that basically 137, about 51%, had substantial improvement. So that still says that about 66% were satisfied. With that said, there is a poorer prognosis group. If they were work comp, if it was a medial meniscus, if it was a degenerative meniscus, or it was a root tear, they tended to fall in the poorer patient group. So this is the challenge I have for everybody in the audience, is we all have this patient, 52-year-old woman with knee, moderately overweight, degenerative meniscus pathology, and you've done what you're supposed to do. You failed exercise, weight loss, cold therapy, acetaminophen, nonsteroidals, whatever other home remedies, and they still have problems. So do you deny the scope or do you scope them? So quick audience quiz. Who's going to scope that person? Who's still willing to scope them? Interesting. So for this audience, the answer is probably not. I'm going to suggest to you one of the things that I would approach is a shared decision making. What we know that is that if from a clinical perspective, you used evidence-based medicine, you participate in shared decision making, including a patient-centered communication, you'll ultimately get a better quality and patient satisfaction. So what I would suggest is that you get the patient's participation, you educate them about all the different options, what the success rates of each, including arthroscopy, and then once they make a knowledgeable decision, then it's actually still okay to do it. Because I know personally, I've had a number of patients who have had positive outcomes from arthroscopy. Maybe not permanent, maybe not long term, but they can get 2 to 4 years of positive outcomes before they progress on to the next step. So if you look at the series of potential treatments for degenerative meniscus pathology, going from the top to the bottom, it's an increasing risk. So I'm going to talk to every one of my patients about each of these, and I'm going to tell them what their pros and cons are of each, and that which ones has an increasing risk. So I'm going to start everybody on weight loss and fitness. I'm going to then consider a deloader brace, although there is some expense, and you have to address compliance. Tylenol and nonsteroidals certainly is possible, but you have to then monitor them if you're going to use them for anything longer than 2 to 3 months. Same things for any other significant medications. How about supplements? The American Academy of Orthopedics at one point said glucosamine supplements were not recommended. Actually, they changed that. They said that you could use those types of supplements. What do? I tell my patients it's about 50-50. Flip a coin. Maybe they work, maybe they don't. You do your own self-trial for 1 month. See how it feels. If it works, great. You can keep using it. If it doesn't work, then stop taking it. Steroid injections certainly can be effective, but I think that they are relatively time limited. And what we know from recent studies is that if you're doing steroid injections and you're going to do a total knee arthroplasty, you have a higher risk of potential complications. So you have to factor that into the discussion. Viscosupplementation, more risk. So as we go from the first things, now we're doing injectables, there's somewhat more risk, can last longer. Some studies for PRP, in particular mesenchymal stem cells, would suggest that they are as effective or more effective than viscosupplementation and last a little bit longer. And then finally, if I walk my patient through all of those things, I've stepped them through there, and they sit there and go, I don't want a total knee yet. Yes, and I'll tell about 50-50 based off of the work of the Cole group. I'll say 50-50. If you still want to try an arthroscopy, it's okay. Somewhere in that, we've already had some talks about osteochondral treatment. Certainly, I'm talking about degenerative meniscus, but somewhere in that choices list for your patients, you're going to have to talk to them a little bit about what you're going to do with treating the degeneration. If it's just a little light cartilage stuff, yes, you're just going to do a light debridement when you're taking care of the meniscus. However, talking about cartilage restoration for more significant things, this is a review article from 2023 that shows satisfaction and return to play of 75 to 86% with osteochondral transplants. And you can see with MACI, all of the different patient-reported outcomes significantly increased with the use of MACI if it's a treatable lesion for such things. Cross-sport comparison of professional athletes for microfracture. Well, historically, we would say actually that basketball is a bad idea. And if you look at the top right over here, this is both basketball and baseball actually had decreased performance over time with microfracture, although Major League Football actually had increased performance. But if you look at satisfaction rates and ability to return to play, although, yes, you're going to tell them that there's a risk, those athletes actually were able to return to play. So some meniscus surgery pearls. Clearly, repair them if possible. Save the meniscus if at all possible. You can, if you're going to go to do that surgery, you're going to remove only the dysfunctional portion. Minimize cartilage debridement. Be gentle with remaining cartilage. Liberal use of additional portals, and consider pie crusting the MCL to open up the space if you have difficulty getting to the meniscus. And then adjuvant, even at the time of surgery, you can use viscosupplementation or PRP injections at the time of surgery, which may help your outcome. In my personal experience using a shared decision-making model with degenerative meniscus, we have found that overall, and this has been reviewed by my residents, overall we've had increased patient satisfaction and outcomes. When they fail, because half the time they fail, they are less litigious because they knew the risk, they knew what they were getting into. There is some patient selection that must be done. Some prefer a definitive doctor, and maybe your patients are like that. They go, Doc, I don't want to hear all this stuff, just tell me what I should do. Well, if they're that way, perhaps then you have to say, well, this is what I would do for my mother, this is what I would do for my family member. But generally, I try to really get them to partner in that decision-making. Then we also have to respect the progressive power of placebo. And so generally, the hottest new option has the most powerful placebo effect. The most invasive option has the most powerful placebo effect. So if we're just looking at saying, randomize this, and some of the studies that say this doesn't make a difference, clearly we have to pay attention that if you're going to use viscosupplementation, if you use PRP, patients are going to think that that's actually slightly better, and they may have a better patient-reported outcome from it. Similar for the more invasive things like surgery. So I thank you for your attention. I thank you for allowing us to participate on behalf of the Arthroscopy Association of North America. A couple little notes for you in case you're interested in other arthroscopic education. The Arthroscopic Association of North America's annual meeting will be held in Boston in 2024. We actually are holding a World Cup of Arthroscopy in Doha, Qatar in November. This is a hands-on course, a cadaver-based course that's available to you. Most of our courses are held at the Orthopedic Learning Center near Chicago, which is one of the hottest, and it's an amazing facility if you've never been there for arthroscopic hands-on education. And here you can see a couple of our lab courses that we have coming for hip arthroscopy, foot and ankle, foundations in arthroscopy, which is a fundamental course. And here's a very advanced procedure-specific course being held by past presidents, Rick Ryu and Nick Scaglione, where basically you can say, I want to learn arthroscopic Latarjet, and they will set that up for you. So you look at anything where it says ANA.org, that's how you get that information, and I thank you for your attention.